In a study published in The Lancet, Huang et al. Reported that 41 patients had laboratory-confirmed COVID-19 infection, and all of them had pneumonia, and mortality in that population was 15%. Infection caused clusters of severe respiratory illness similar to SARS. 15% of the infected patients had cardiovascular disease, and 12% of the patients had acute cardiac injury diagnosed by elevated blood levels of hypersensitive troponin I levels. High plasma concentrations of cytokines were observed in critically ill patients. In another recent report published in the Journal of the American Medical Association, Wang et al. Showed that among 138 hospitalized patients with confirmed COVID-19 at a hospital in Wuhan, China, mortality was 4.3%. Patients who received ICU care were significantly older and were more likely to have underlying comorbidities, including hypertension, diabetes, and cardiovascular disease. Among other complications, arrhythmia was noted in 16.7% of the patients, and acute cardiac injury in 7.2% of the hospitalized patients as diagnosed by elevated serum troponin I levels. Notably, patients who received care in the ICU were more likely to have cardiac injury than non-ICU patients. These findings suggest that cardiac injury may be associated with the serious clinical outcomes of COVID-19. Another very recent study published in JAMA Cardiology on March 25th, 2020, found that among a group of 416 patients with COVID-19 hospitalized in Wuhan, China, 19.7% suffered cardiac injury. Patients with cardiac injury were older and had more comorbidities and had elevated levels of the cardiac biomarker NT-proBNP and the inflammatory biomarker C-reactive protein than those without cardiac injury. Notably, more than half of the patients with cardiac injury experienced in-hospital death in this study. After adjusting for age and pre-existing conditions, including cardiovascular disease, the multivariable adjusted model showed a significantly higher risk of death in patients with cardiac injury than in those without cardiac injury, with a hazard ratio of 4.26 for time from symptom onset to study endpoint. Patients with pre-existing cardiovascular disease might be more susceptible to COVID-19-induced cardiac injury, as approximately 30% of patients with cardiac injury in this study had a history of cardiovascular disease, and this was significantly more prevalent than in those without cardiac injury. These results demonstrate that cardiac injury is associated with an increased risk of mortality in patients with COVID-19. Although the mechanism of cardiac injury is not clear at this point in time, these findings underscore the need to consider this complication in COVID-19 management. In another recent study from China, among 187 patients with confirmed COVID-19, 35.3% had underlying CVD, including hypertension, coronary heart disease, and cardiomyopathy, and 27.8% exhibited myocardial injury as indicated by elevated troponin T levels. Mortality was markedly higher in patients with elevated troponin T levels than in patients with normal levels, 59.6% versus 8.9%. Patients with underlying CVD and elevated troponin T levels had the highest mortality of 69.44%. Those with the underlying CVD and normal TNT levels had a more favorable prognosis, with 13.3% mortality compared to those with elevated troponin T levels and no underlying cardiovascular disease, so that was 37.5%. These data suggest that myocardial biomarkers should be evaluated in patients with CVD who develop COVID-19 for possible early and more aggressive intervention. Patients with elevated troponin T levels differed from those with normal troponin T levels with respect to multiple indices of organ function, including the heart, liver, kidney, and lungs. Notably, those with elevated troponin T levels had significantly higher levels of biomarkers of cardiac injury, including myoglobin and NT-proBNP. As you can see in the visual, plasma troponin T levels in patients with COVID-19 correlated significantly with plasma NT-proBNP levels. Patients with underlying cardiovascular disease were much more likely to exhibit elevated troponin T levels, 54.5% versus 13.2%. And during hospitalization, patients with elevated TNT levels developed more frequent complications, including malignant arrhythmias. This figure from the same study shows the dynamic escalation of troponin T and NT-proBNP levels for patients who died and those who were successfully treated and discharged. Levels of both TNT and NT-proBNP cardiac biomarkers increased significantly during the course of hospitalization in those who ultimately died, but no such dynamic changes of TNT and NT-proBNP levels were evident in survivors. The dynamic escalation of NT-proBNP, considered together with the increased incidence of malignant arrhythmias during the course of disease in patients with elevated TNT levels, suggests that myocardial injury may play a greater role in the fatal outcome of COVID-19 than underlying CVD. There are several questions regarding the potential mechanism underlying COVID-19-induced myocardial injury. In patients with underlying CVD, viral illness can further damage the myocardial cells through several mechanisms, including direct damage by the virus and systemic inflammatory responses. Patients with CVD are more likely to experience myocardial injury after COVID-19 infection and are at higher risk of death. The exact pathophysiological mechanisms underlying myocardial injury caused by COVID-19 is not fully understood. A previous report showed that in 35% of the patients with SARS-CoV infections, the SARS-CoV genome was detected in the heart, raising the possibility of direct damage of cardiomyocytes by the virus. SARS-CoV-2 may share the same mechanism with SARS-CoV because the two viruses are highly homologous in their genome. In the study by Guo et al., which we have discussed, inflammatory biomarkers such as high-sensitivity C-reactive protein were significantly higher in patients with elevated troponin T levels. As you can see here, plasma TNT levels in patients with COVID-19 correlated significantly with plasma high-sensitivity C-reactive protein levels. These findings suggest that myocardial injury may be closely associated with inflammatory pathogenesis during the progression of disease. Other retrospective studies that have examined patients with COVID-19 in the context of cardiovascular disease also found elevated levels of cardiac biomarkers such as troponin, myoglobin, and inflammatory biomarkers such as CRP, IL-6, serum ferritin in non-survivors. These studies are further suggestive of a high inflammatory burden in COVID-19. It's possible that myocardial injury may be associated with infection-related myocarditis or inflammation of the heart muscle. According to Dr. Mohammed Majid, a cardiologist and assistant professor at McGovern Medical School at UT Health in Houston, inflammation appears to be the mechanism that best explains the association between cardiac injury and COVID-19. Considerable number of patients die from cardiovascular complications during every flu epidemic. Lessons from the previous coronavirus and flu epidemics suggest that viruses can trigger inflammation, which can damage heart arteries. According to Dr. Majid, the next step is to use anti-inflammatory medications to combat the effect of these viruses on the heart tissue. Dr. Majid is the first author of a review paper published in JAMA Cardiology that describes data from several previously published studies on the potential effect of COVID-19 and other coronaviruses such as SARS and MERS on the cardiovascular system. The visual here is from the review and illustrates how viral infections can cause acute coronary syndromes, arrhythmias, and the development of or exacerbation of heart failure. COVID-19 may be associated with a high inflammatory burden that can induce cardiac arrhythmias and inflammation of the blood vessels and the heart muscle. COVID-19 can also have fatal consequences for people with underlying cardiovascular disease, but according to Dr. Majid, it's likely that even in the absence of previous heart disease, the heart muscle can be affected by coronavirus disease. Overall, injury to heart muscle can happen in any patient with or without heart disease, but the risk is higher in those who already have heart disease.